Good evening, all. Welcome to the next of our consultant forum meetings. It's just gone 6 o'clock, so we'll make a start. It's a real pleasure to welcome Professor Mihaela van der Schaar to speak to us today. Mihaela is a professor of machine learning, AI, and medicine. And she is the founder and director of the Cambridge Centre for AI in Medicine, a really exciting translational cross-academic specialty post and institution. So I think it's going to be a really exciting few years for this work, and we're really looking forward, Mihaela, to hearing how, as clinicians, we can hopefully work with you and your colleagues and perhaps not be afraid of machine learning and what it means, and perhaps learn how it might help us and our patients. And it's great to welcome you, and it's great to have you here following your previous academic work in Oxford and UCLA. And so welcome. We're looking forward to hearing from you. Thank you.
I'm sorry for this. Can you hear me now? The
Yes,
little glitch. Apologies for that. I've done this billions of times, and yet every time. Thank you very much for the kind introduction, and thank you for having me here. I'm really delighted and thankful for this invitation, because I really hope to recruit as many of you from the clinical community to join forces with machine learners like me, to really think about how these tools that we are developing can hopefully empower you. And what I really want to do in the talk today is to convey this message that I strongly believe that this revolution in machine learning, using machine learning to change really healthcare and medicine, needs to have you, the clinicians, as the drivers. Currently, a lot of the existing research in machine learning is driven either by machine learning researchers or AI researchers, either in academia or companies such as Google and Microsoft, and also by a variety of economic forces. But what I really would prefer to see is to have you join forces with us and tell us what type of tools you need or you do not need to empower you to better serve the patients that you are seeing. So the focus is today to tell you a little bit about machine learning and tell you about the tools that we have co-developed with several of your colleagues, and try to hopefully encourage you to envision a future in which you can use such tools to empower you, not replace you. The father of modern medicine, William Osler, said, if it were not for the great variability between individuals, medicine might as well be a science, not an art. I always like to start with this quote because this shows that actually medicine is very hard. The reason medicine is an art is because of the variabilities between individuals, their genetic background, environmental exposures, lifestyles, histories, and interventions. And this often leads to different risks, variation in symptoms, health and disease trajectories, and responses to treatment. And really, the art of medicine has been to make judgments on the basis of this complex, longitudinal, and diverse information to manage patients. And what I believe that machine learning and artificial intelligence can do is to turn this art into a science by empowering you, the clinicians. I want to say it very early on that I do not believe that machine learning can do medicine. What I believe it can do is provide interpretable, trustworthy, and actionable information in the form of risk scores over time, recommendations for treatments, development of new guidelines, new hypotheses. And all of that hopefully can empower you to better take care of the patients in front of you. So I often characterize what I believe that machine learning can do in 6 different categories. Machine learning can transform healthcare by delivering precision medicine at the patient level. And I'm going to often talk about something that goes beyond precision medicine. I'm going to talk about bespoke medicine. I'm not going to define a lot the term today, but if you are interested, you can find much more about this in a resource that I'm going to present in just a little bit. We also want to use machine learning to understand the basis and trajectories of health and disease progression, empower healthcare professionals as well as patients, inform and improve clinical pathways, better utilization of resources, while also being able to cut costs, transform population health and public health policies, and enabling new discoveries, both clinical as well as therapeutics. I have developed a framework that I feel it's useful to think about what machine learning can do. And I divide this framework, and you can read more about this framework on our website, in 4 different categories. Some that are patient-oriented, some that are profession or clinician-oriented, some that operate at the individual level, 1 patient and 1 clinician, and some which work at scale at the level of an entire healthcare system, or even at the level of a country or even across countries. And the 4 different areas that I'm working on and where I believe that machine learning can help are, if we think about patient-oriented analytics and intelligence using machine learning, we can deliver what I call bespoke medicine, which goes beyond precision medicine, which often just looks at information from genomics, clinical information, as well as other sources of information to issue risks, competing risks, longitudinal trajectories, but rather it changes this perspective over time as the patient develops different morbidities and comorbidities, is treated in a particular way, may have a particular intervention applied to him or her. So what I want to differentiate here as opposed to precision medicine is that things may be changing over time, potentially quite dramatically, as the patient may change themselves or may develop other diseases or may be treated in a particular way. Profession-oriented, I'm going to talk a little bit about the need to build personalized machine learning assistants that are supporting you, the clinicians, and which are not one size fits all, but rather are personalized to your own needs and to your own likes, such that they are providing useful information and also trustworthy information. Also, this can enable you to better communicate with each other in multidisciplinary clinical teams, or even to communicate better with patients and their ecosystem. Also, these tools are useful to better discover and disentangle a variety of risks, and also to understand and learn across healthcare systems and even across countries. So there's an enormous opportunity to integrate a wealth of information to learn at scale about what works in a particular ecosystem or for a particular class of patients, and translate that from one scenario to another. And COVID has been a fantastic example where we can see that interventions and maybe treatments or policies applied in one ecosystem may or may not be applicable in another, with the opportunity to learn from each other again. Then profession-oriented and at scale, this is not only, and maybe an area where machine learning is maybe less cool, but equally important, is in enabling better systems, pathways, and processes, really enabling us to determine when a patient should be seen, how it should be seen, what's the best pathway of care, what is the optimal patient pathway, given their unique characteristics, given the resources that are in the system at that moment in time. And again, this is pertinent not only to pandemic like COVID, but also to diseases such as cancer, and that enable cooperation across systems and again, across ecosystems at the level of NHS or even at the level of multiple countries. Most of this research is done together with my PhD students and my postdoc. Usually research teams in your domain are very different. In my case, I mainly work with young, super bright PhD students. that are also very much aligned with this vision and are eager to work together to develop tools to empower you, the clinicians. So what do I have in mind? I'm going to talk about a data-driven machine learning ecosystem, which can empower everything from clinical research to patients, to hospital administrators, to healthcare bodies, to policymakers. But my main focus would be on you, the clinicians. And actually, most of the research in our lab focuses on empowering clinicians. We are working with a variety of clinical collaborators, but my 5 closest collaborators are among your colleagues. They are all in Cambridge, and I'm sure you know them well. They are highlighted here. There are other collaborators. The list is only partial, but I wanted to acknowledge Eoin, Alex, Ari, Andres, and Vincent for their kindness and time they spend with me and my team to teach us what they need and to teach us about medicine such that we can build tools like the one we have built together with them. Also, I have developed 1.5 years ago an engagement session for clinicians that are interested in machine learning and to learn more about it and shape these tools. We call this Revolutionizing Healthcare. Please, if you are interested in learning more about machine learning, subscribe to these sessions. They are taking place once a month. And really, we have around 500 clinicians from 4 different continents enrolled in these sessions. And we have very good and interesting roundtables and discussions to try to understand what type of machine learning tools are useful for different types of care systems, from cancer to cardiovascular disease, from early diagnosis to machine learning interpretability and beyond. For instance, the next session will be a double header on February 8th and March the 10th, where we are going to talk about early detection and diagnosis. And I have a variety of clinicians across very different disciplines, some from Cambridge, but many from outside the UK even, joining us to think about what machine learning can do for early diagnosis and detection. So if you are interested, please join us by subscribing to this session. Now, what we have in mind, we would like to build some type of integrated clinical decision support system that's enabling you with a variety of useful analytics. So this you can envision and be something on top of Epic, can extract a lot of information and provide this actionable intelligence. What type of actionable intelligence do I have in mind? I'm going to show you a variety of settings, but really I would like to see an entire pathway of care. From the moment the patient may have some symptoms or maybe not even have symptoms and do prevention, all the way to screening, to personalized screening and personalized monitoring, to early diagnosis, to identifying what treatments should be given when, for how long, and in combination possibly with what other treatments, what needs to be done inpatient or outpatient, and also how the stakeholders involved in the healthcare system need to collaborate with each other. I'm going to start with one area that we all know it's important, and that is the trajectory of health and disease of a patient. One of my collaborators, Dr. Cem Rajbas, often says to me, well, medicine is a trajectory. Medicine is actually a time series. And indeed, we have developed over the various years a variety of tools that are taking time series data, diverse time series data, and build analytical tools such as dynamic forecasting, time to event analysis over time, treatment effects over time, early diagnosis, screening, clustering, and phenotyping. So for that, we have developed, on one hand, machine learning analytics to do all that, and I'm going to show to you a few examples. And also we have developed methods and methodologies that make these tools more robust and more useful, from more interpretable to providing discovery and understanding of what has been learned by machine learning. It is no longer true that machine learning methods are black box, as I'm going to show to you next. We really can learn and understand what they have found. Also, we can provide uncertainty estimates such that we know when we can trust the various analytics and when we cannot, and much more. And of course, these different tools can work with each other and are interconnected. if you want to listen and hear more and read more about these tools on machine learning for time series, which are not enough talked about, you can take a look at our website under research pillars. We have a whole section on time series that you can take a look at. I'm going to talk briefly about what I have in mind. So often we are learning from a variety of streams of measurements. What you see here is a scenario from a hospital setting where a lot of measurements are collected. So this is a scenario like often I encounter when I work with Ari Ercole in the hospital, where we take measurements of patients either before going to the ICU or in ICU. However, this is also the case in secondary care, where we have much fewer measurements. The problem is often much harder because we may have only few measurements collected at different moments in time and of different types of information. However, in all these settings, we would like to integrate these diverse and sparse and possibly irregular sampled data, but what I'm often calling informatively sampled data. So the fact that the data is collected or is not collected may be informative, and we can learn from it. So rather than just say, oh, I want to have a perfect data and I want to learn from complete data, we machine learning do not do that. We like to learn from complex, messy data, because often the sources of, let's say, information, inclusively the fact that we do not have information at a particular moment in time, may provide us with information actually that we can learn on the basis of. We also have multiple outcomes of interest. Very often we are not interested on only one event, for instance, a particular disease or a particular outcome, recurrence of cancer, for instance, but rather we are interested in a variety of events that may be evolving over time, possibly multiple morbidities and comorbidities, but also side effects of medication and so on. Unfortunately, very often staging of disease is not possible. And even in diseases like cancer, where we have some type of staging, this is often not sufficiently, I would say, quantified. But in many diseases and in many complex settings, this is not even possible. So what machine learning, one of the things that I will very briefly just touch upon is the ability to have much better quantification of progression of complex diseases, which could help us with better understanding how to treat, when do we see that the patient is changing and maybe moving to a different phenotype, but also may help us with early diagnosis. As I already alluded to, this is also important for understanding how patients may evolve differently over time. So the idea of clustering and phenotyping, but not only at the simplistic static level, but also dynamically, because patients may evolve over time and may move to other classes, and their outcomes may differ than initially believed. So what do? We learn from such diverse data and try to build machine learning models that use such complex electronic record data as well as technical knowledge to learn and model complex disease. And what we do with machine learning is we're both involved in how to model these diseases, as well as how can we learn from the sources of data, the parameters of this model. This is done at what we call training time. And then we freeze the model. We no longer use the data that has been used for the training separated. And now at runtime, or test time, we are looking for the patient in front of the clinician. How can we provide outcomes, and how can we make dynamic forecasts in this case, because we have time series data of various events of interest or even different biomarkers. So one can ask, is this particular event going to happen? Is recurrence going to happen, and when? But also potentially, is this biomarker that I'm measuring, which may be a blood test or it may be a tumor size, how is that evolving over time? So this is also part of what we can provide. And in this way, we can do that not only, we can do that at the patient level, we can also do that, of course, at the population level, but we can also identify subclasses of patients that may behave differently. The most important part, though, is of course the personalization we can provide for the patient in front of you. So it's no longer a population level prediction, but rather a personalized prediction, and associated with it, we have confidence associated with this prediction. Cutting edge in medicine right now, I would, for time series models, is often as highlighted here. People often use what it's called Markov models, and I promise this is the last equation you will see. They use, and what do Markov models mean? They mean the fact that actually every prediction of progression, probability of progression, given the current state, depends only on the current state the patient is in. So if the patient is, for instance, in disease stage 2, what has happened to the patient before disease stage 2, how it got there, when it got there, how long it has been in stage 2, does not matter. All it matters is that the patient is currently in stage 2, and every prediction is based on the basis of that. Well, there are many problems with this. One of them is the history doesn't matter. The duration of being in a particular state didn't matter, whether somebody has experienced a particular, let's say, cardiac issue for 2 minutes or for 5 years, it doesn't matter in this model. So it's clearly not very good. It's also one size fits all. It also requires us to observe on the basis of symptoms and biomarkers the exact stage of disease, which is irrealistic. And it models just one disease at a time. If the patient has 2 diseases, one will need to have 2 different models, and how these diseases interact is not it's not possible to model in this way. And as I mentioned, this is done often at the average level. So this is, if you like, state of the art in many of the medical papers that I see and I read. Again, many challenges associated with it. The fact that, and yet history does matter in medicine, how the patient got there, for how long the patient has been there, potentially how it was treated to get there, all matters. Also, we wanted to move beyond population level to patient level, individualized trajectories of disease. One way in which you may come to mind now, you will hear a lot in the media about deep learning, and deep learning in the form not of convolutional neural networks, which are used often for radiology, but rather we all use, if we use natural language processing tools, like for instance, translating from one language to another. If we ever use Google to translate from one language to another, we often use a time series model that's based on a deep learning methodology that's called recurrent neural networks. Well, these methods, just taking all off-the-shelf machine learning and applying it to medicine, it doesn't work well. Why it doesn't work well? Because for having a comprehensive and useful for you, the clinician, trajectory of disease, we need to have accurate forecasting, and we need to understand progression of disease such that you can act upon what has been provided to you as a prediction. So we have developed for that something that we call attentive state space models, which enable us to look at the trajectory disease over time and have interpretability associated with it. I will not go into the details of how we do that. All I'm going to say that if you are interested to listen more about this, I've given a lecture around 5 years ago about how we build these tools and how we apply them actually in a hospital. And actually at the time, the work that I presented here was applied at UCLA Medical Hospital in Los Angeles. But this type of methodologies where we are looking at an entire trajectory of disease and issue predictions has been applied not only to ICU and hospital care, but also for cancer, cystic fibrosis, and Alzheimer's disease. Now, let me go one step further and say that we don't want only to make predictions over time. So given the past history of the patient, what will happen in the future? We also want to be able to do time to event analysis. We want to say, I have certain observations as highlighted in here, and I'd like to say, what is the chance that the patient is going to have a particular incidence of breast cancer or cardiovascular disease. And this type of probabilities and how do they change over time as we make more observations about the patient, and this forecast is what we are able to provide as well. In a recent session of this Revolutionizing Healthcare engagement sessions that we've had in October, together with Vincent, we looked at how we can use these tools to do dynamic survival analysis for prostate cancer. So if you want to see not the tools, but how they have been used to integrate the longitudinal information that exists in the form of, for instance, repeated PCA measurements like Vincent is accumulating over time for a particular patient, and how can we now use the machine learning tools we have developed to make projections of the probability of the patient, for instance, having cancer, or probability of the patient dying from a particular from prostate cancer, or from another event in the future. You can take a look at this kind of tool that we have built, which has the analytics we developed behind it, but which provides a dashboard that Vincent has created with us and can show to you what we can do to really use longitudinal information, which in this case is relatively simple. In the case of ICU care, it's a lot more. And you can see how these longitudinal trajectories of disease are built and how projections are made in the short term and in the long term about events of interest. Now, let me say one more thing. Another thing that's related to this is how morbidities and comorbidities may play a role in these trajectories of disease. One big problem with current models for morbidities and comorbidities are that they are at the population level, so they are one size fits all, and they are static. So often people say, well, these morbidities affect these other comorbidities. Well, that's not very useful. What we need is something that's personalized. So how for the unique patient in front of you that may have this particular genetic characteristic or this family history, the morbidities are going to affect each other. And also you want to see probably how over time, as more morbidities are appearing, when in the future they may affect another comorbidity. Because it is not that they affect each other, it's also when, and what is the window and opportunity you have to intervene to maybe counter the effect of this morbidity on another comorbidity. So for that, we built actually some machine learning methods that enable us to build this personalized comorbidity networks where, given the characteristic of a patient and the current morbidities, nuance are triggered. And this looks kind of very geeky, but actually we apply this to cancer and to bowel cancer, and some very interesting findings on the basis of this work. Now, another thing I want to talk about is how can we cluster patients? Currently, when you think about phenotyping and clustering, often one thinks about static clustering, and that can be done, but this is not always enough. Often you would like to understand whether these clusters, these phenotypes are changing over time as the patient is progressing through a disease. And conventional notions of clustering are often looking at how patients are similar in terms of their observations, but it is useless for medicine. It is not important that two patients have similar observations, but rather that they have similar outcomes, that the outcomes of interest, adverse events, death, or any other event is similar in these two classes of patients. And this may be in two patients that may seemingly be quite different, but actually they exhibit similar outcomes. It is such an outcome-driven or event-driven, event of interest-driven phenotyping that's of interest. And then something very interesting happens in terms of understanding as well, because maybe two patients that look the same are actually evolving very differently. And one can then understand the reasons behind it. Are there genetic reasons? Are other reasons that have led to this divergence evolution? And conversely, why do patients that may look quite different are evolving similarly? What makes them similar? What are their unique characteristics that make them evolve in a similar way? So we have developed for that some work. We're using machine learning to enable us to integrate diverse information, observations, and outcomes in secondary care, and build this concept of outcome-driven temporal phenotyping. And the initial application was done to cancer and was built on the basis of the cancer registry. But the more recent use of it was done together actually with Vincent, again, for prostate cancer. And you can see more about this temporal clustering in the Revolutionizing Healthcare session that has Vincent as our primary guest. Now, fine, patients are evolving over time, but one may wonder, when should the patient come next? Often we are very regimented and always say the patient should come back in 3 months, in 1 month, in 6 months, in 2 years. But the reality is that depending on how this patient may evolve, they may need to come faster than this preset times or much later and nothing bad will happen. So we need to move to a personalized monitoring and screening setting. I'm going to mainly talk about monitoring here. And the key point that I like to highlight is that we have developed a variety of tools to determine what, on the basis of the information we have about the patient so far, when in the future we should ask the patient to come back, how should he or she be screened, or what type of information should we monitor? Should they come from a blood test? Should they come for a visit with a clinician? With what clinician? What type of test? And how will that be informative of the subsequent trajectory of the patient? So these type of questions about the value of information are very much associated with the value of monitoring and enable us to depart from conventional one-size-fits-all methodology and move into a much more cost-effective and patient-centric approach where we are able to estimate the value of an additional meeting with a clinician or additional screening for the decisions that need to be made on behalf of the patient. I'm not going to talk about early diagnosis because I'm going to have an entire session about it on February 8 and 10 in these discussions with clinicians in Revolutionizing Healthcare. So please come there if you are interested in, or just subscribe and you can watch it offline. What I want to talk about now is, what about treatments? Because we can make a lot of projections in the future. It would be interesting to see if we can provide you with some information about what treatments may be good and when. So the focus here is, again, individualized estimation of the effect of a treatment on a patient. And for that, we move beyond predictive models into what we call causal inference models. A lot of resources are available on our website on how to build such causal inference models for time series data. And the focus here is to learn from observational data how to treat a patient, when to start treatment, and also when to stop treatment. And even more than that, try to understand when multiple treatments will need to be given and what is the value of them. We are learning that on the basis of the observational data that we have at hand. I am not going to talk too much about this today because, again, we have a session together with Owen in Revolutionizing Healthcare. And he very eloquently talks about these methodologies that our lab has developed. And he also talks about how we have collaborated with him to build a simulator that enables clinicians to determine when to treat and how to assess the value of treatment. So if you want to hear more about that, I prefer you to take a look at Owen's presentation because he's very, very well presenting these methods, much better than I can. Now, we want to build an ecosystem of tools. We have a variety of tools, as I mentioned to you, and many more that I didn't present. And for that, what I want to do is not to outsource or replace you, the clinician. I want to outsource and replace me, the machine learner. So ideally, I'd like to be in a setting where the tools we develop are so powerful and so robust that anyone with a little bit knowledge of data science can partner with you, the clinicians, and build models to empower you. So we are working towards building an ecosystem of robust tools that can do that. And for that, automated machine learning is very important. And again, automated here stands not for automating the clinician, but rather automating the machine learners. So we want to be able at the push of a button to build machine learning methods without needing for you to deal with the machine learner at all. For that, we have built these automated machine learning tools. And the reason that they are important is each one of you may have a different disease of interest. And each one of you may have a different data set. And I do not scale well. I would love to work with a variety of clinicians, but the reality is that we don't scale. So what I always thought is it will be a lot better and more robust even to have a tool that at the push of a button, you can put the data in and out it comes the particular machine learning tool, whether it's a risk score, whether it's a competing risk score, whether it's a time to event, whether it's a time series model for predictions over time, whether it's a treatment effect model that comes automatically for the data that you have. An example of that we have built early on for risk prediction, which is the simplest of scenarios, where we have noticed actually that different models are best for different data sets. So while, for instance, for a particular cardiovascular disease, this particular model may be best for the transplantation data set in, let's say, heart transplantation, this totally different data set, machine learning model is best. So it's not that one machine learning model is best. And at times I smile when I see the papers in the medical journals or even papers in Nature, because they use very simplistic and outdated machine learning models. And part of the reason is that these models are hard. So in order to make them much better and much more robust, through automatization, we are able to select among a humongous set of models that are developed by the machine learning community and do that in a robust way, rather than cherry pick based on our limited maybe knowledge. For that, we have built a tool that we call autoprognosis, which is able to take any clinical data set that's cross-sectional and output predictions as well as explanations. Initially, we developed tools for cardiovascular disease, for cystic fibrosis, for prostate cancer. For NHS, we worked on COVID-19 and also more recently on breast cancer. And we have not only done it for cross-sectional data, but also for time to event analysis, for competing risk, for treatment effects. And together with Ari, we also built this ecosystem for time series models. And if you are interested to understand how you can use machine learning at scale, cutting edge machine learning at scale without really needing to interact with machine learners, please take a look at this website that we have created on automated machine learning. One thing that's nice about it is that even the visualization can be done automatically. So we can build at the push of a button, even not only the machine learning model, but also the visualization. And this is what we have done relatively recently, where we built a tool for prognostication and treatment benefit prediction in breast cancer. And we have done that with a variety of collaborators, both from Cambridge as well as from Oxford and NHS. And the focus here was to predict survival of women diagnosed with breast cancer for different types of treatment decisions. We have validated this model in 2 different countries. So often AI models and machine learning models are not validated more than in one very small population. We have been very fortunate because we worked with NCRAS. So we had a fantastic data set from the UK, and we have validated in a huge amount of patients in the United States. So we had more than 1 million patients involved in this. I'm not going to go through the details of this. All I'm going to say is that an automated machine learning framework was used to issue this type of prediction for breast cancer mortality as well as mortality from other risks. And the methods that we have developed are doing a lot better, both than statistical methods such as Cox proportional hazard, as well as state-of-the-art currently used in medicine, NHS Predict. So these machine learning models are significantly better at all the different time horizons, both in the data set that was used initially for training, which was the UK data set. What is also wonderful is that for the United States data set, so the data set on which the model was not trained, we just took the model off the shelf and we used it to predict in the United States. Again, we have significant performance improvements as opposed to the existing models. And in our Nature Machine Intelligence paper, we go into details as to why this, what are the reasons behind it, and the nonlinear interactions, the complex nonlinear interactions that have been found through this model. Now, why are models like this not enough adopted? One important reason is the need for transparency and the need to understand what the models have learned, and also to know when can we trust the models and when we cannot. So this issue of machine learning interpretability has been at the core of a lot of my research. And you see here a session, we have multiple sessions in Revolutionizing Healthcare dedicated to interpretability. So please take a look if you are interested. And also on our website, I've distilled what we have learned from discussion with clinicians in several blogs. So you can take a look and they are easy to read. And we have identified 3 main areas for a need for explanation. And what's wonderful is that I didn't know of the third till I discussed with several clinicians. The first one, and that's the one that's most often used so far, is patient features. So what is the model looking at, the machine learning model looking at when issuing a particular prediction? The second one is, can we come up with a set of examples that are used to make the prediction? And number 3 is, can we have very clear risk equations associated with a model prediction? So people like regression at times because there is a very clear equation that can be outlined, a linear model of the risks and how they interact with each other. We can do absolutely the same now with machine learning. So we can discover the exact equations associated with what the machine learning has learned, thereby having exactly the same interpretability as statistical methods have. Very briefly, explanatory patient features. The question here is, what has the model looked at when issuing a prediction of risk at one moment in time or in the temporal setting across time? And we want to do that both for the patient in front of you, such that we are able to say, for this person, we issue this prediction because of these particular features, but also we want to do that at the population level. For that, we have developed machine learning methods, like this method that we call here InVase, which shows that, for instance, for Nancy, this particular machine learning model has issued this particular prediction due to these 3 features. And for another person, for Mary, maybe there are different features and a different number of features. This is one way in which we can provide understanding and we can X-ray the black box. And indeed, I've built together with Cancer Registry in the UK, together with them, we have built an ecosystem 3 years ago, and we can find all sorts of resources about it online. And there we show, for instance, how these predictions depend on what machine learning model has learned and which features are important, how are they important over time, how are differently important over time, and how they are differently important across patients. But this, so for instance, this is a particular case, and these are the features associated with it. But ideally, we want to improve on top of that, because they do not explain always why some features are important. And we also want to keep the humans in the loop. And these methods don't adapt to the user knowledge. So for instance, if I talk to a collaborator like Vincent here in the United Kingdom, he will have one particular knowledge and patient population in mind. And if I talk to my former collaborators at UCLA in the United States, they may have a very different population cohort in mind. So the question, this is why the second type of interpretability emerged through discussions with clinicians. We wanted to identify for different types of patients and different types of clinicians. For instance, as a clinician in the United States, seeing Nancy, who is in the United States, and she has a certain patient population in mind. And when she wants to debug and understand the predictions of and the recommendations of the black box model. So this provides us with user personalized interpretability, where the user here is Nancy, but the user, Nancy's clinician, but the user could also be Nancy, and she may want to have an explanation according to her patient knowledge and the women that she knows that have cancer. So the focus here is for the user to provide, in this case, the clinician, to provide what we call a corpus of historical patients. To say, these are the patients that Nancy wants to understand what the machine learning model has looked at when issuing these predictions. So it wants to have example-based explanations that are providing references to a selected set of patients that Nancy has seen in the past. And indeed, we can provide that. We can explain how Nancy's prediction relates to the predictions of other patients that Nancy has seen in the past, and how these patients are different, and how they have been weighed together to issue this particular prediction from Nancy. So if you like, these are clones of Nancy, not clones, these are other patients in the data set that need to be perturbed in a particular way to issue a prediction for Nancy. And by providing such information, you can debug what the machine learning has learned and how it has learned to aggregate past information to issue this prediction. And the clinician can debug that by comparing it with their own perception of how patients should be integrated, to how your own patterns of integration of the past cases you have seen play a role in estimating a prediction for the patient in front of you, and you can compare with what the machine learning model has done. I'm not going to go into the details of this too much, but we can do that for both different countries. So we can, for instance, start with the data set in the UK, train a machine learning model to predict mortality in the UK, and then have an American and a British doctor wanting to understand these predictions. And the American doctor might use examples from the United States, the British doctor from the UK, and we can help them have these different types of representations that are different and based on different patients for the current patient. So even though they are looking at the same patient in front, so let's say one particular patient is viewed by two different types of clinicians with different experiences, the explanations could differ.
Mihaela, I don't want to disturb you in full flow, but you asked me to give you a heads up when time was starting to run short. So I'm just doing that.
I'm going to wrap up. Wrap up. Thank you for that. So let me say that this is one type of explanation. A final type of explanation is we can give real equations. So now we have a methodology that can take any black box model and turn it into an explicit formula. So for instance, in this case, we can take the autoprognosis example that I showed before for breast cancer and have equations associated with a particular prediction that's made. And these meta models, which are these transparent equations, can then be used to issue predictions. I'm not going to discuss this further. You can take a look at our natural machine intelligence. If you also want to discover dynamic laws, I talked a lot about static prediction and static laws, but if you want to learn and unravel from data dynamic evolution of systems, like for instance, the temporal effect of chemotherapy on tumor volume, this can also be done. And indeed, we move beyond just predictions into real equations that can be debugged and understood. Finally, we not only issue predictions, but also confidence estimates associated with the predictions. So we are able to tell you how confident we are, for instance, for Nancy, and how very unconfident we are, for instance, for Mary. And this can inform your decision making. Finally, and I'm going to stop here, clinicians you yourself have different and diverse knowledge and diverse expertise. So we would like to learn from your decisions to develop better clinical practice guidelines and eliminate undesired variation in practice by building more robust and stronger guidelines. For that, we have developed a new framework that we call quantitative epistemology, which stands for the study of knowledge in a more quantitative way. And the focus of this machine learning tool is to enable clinicians to develop better decision support systems, but also better guidelines. If you want to hear more about that, you can take a look at our website. And with this, the only final thing I wanted to say is that if you want to get engaged with our group, please reach out or join the sessions that I mentioned on revolutionizing healthcare. If you want to get involved in our Cambridge Center for AI in Medicine, please send an email to either me or Andres, and we would be delighted to tell you more about the activities we are doing. And hopefully you can join forces with us to really build a vibrant environment in Cambridge where machine learning is not feared, and rather you join forces with us to build tools and dream the future such that the tools that we can build are really truly useful to you, and we can shape, hopefully, healthcare together. Thank you very much for giving me the opportunity to talk.
Thank you. That was absolutely fascinating, and I think a testament to how interested everyone is. We've had a very, very strong turnout tonight, and I'm sure that many other people will listen back to this when the link goes around afterwards. I'll ask everybody just to have a think if they have any burning questions they'd like to pose to Mihaela, and to put their hand, raise their hand on the Zoom facility if they do. Whilst people are thinking, I'm just wondering whether there are particular patient populations, particular disease processes, both benign and malignant, that you're absolutely interested in engaging with clinicians, or is it?
I'm very happy that you asked me that, Justin. Thank you for that. I am a machine learner. I do not know medicine. My father was a clinician, but that's the only knowledge of medicine I have from hearing him here and there. I am actually interested to work with diverse clinicians in a variety of fields. So I work, as you see, with transplant clinicians, with cardiovascular clinicians, with endocrinologists, with ICU care. I do not have a particular disease that I'm interested in particular. I have some interest in cancer because I have a lot of family members that have died of cancer, but the reality is I'm eager to work with anyone, and hopefully these tools that we are building could really transcend a particular disease. So what I'm trying to say is also many of these machine learning methods, they may have been developed for cancer, but they are equally good for transplantation. They have been developed for supporting clinicians for treatment effect estimation in the ICU, but may be useful for Alzheimer's. So my point is that very often these tools, if they are well thought, and what I'm searching for among you is people that want to join forces with us to think carefully about what tools are useful for you, the clinicians. If we develop them well, they can be used in other diseases, other populations, and at other moments in the patient trajectory. It is my belief. We have some canonical tools.
So if anyone has any thoughts of interest that they should be in touch, I think is what you're saying, and then explore the options. Is that fair?
Yes, if
okay.
That's possible. And also
Perfect.
I would like to advertise one more time these revolutionizing healthcare sessions, which are really aimed at building a community in Cambridge, but the community is larger than Cambridge. We have, as I mentioned, people from all different types of countries, and many of your colleagues have been some of our key contributors. That's a good place to kind of come and talk to us about all sorts of ideas. And if you have a particular area of interest, we can engage either like through the sessions or through the Cambridge Center of AI Medicine, or just with me personally.
Thank you
as well.
Well, I'll make sure that all the joining instructions are circulated along with along with the recording. I'm just waiting to see if any hands go up, so I'll ask you another question if that's okay. In terms of obviously the disease process outcomes is a lot of what you've spoken about, but in terms of healthcare management and efficiencies, do you even envisage a role where, for example, two examples off the top of the head, after surgery you can predict whether patients are going to develop complications and therefore keep some in longer, send some home sooner, and patients coming in through an acute medical take, would you envisage in 5 or 10 years time you can stop some coming in and and send them home on a machine model basis? How do you see
Yeah,
those?
so Justin, so thank you very much for this. This is something that's not future, it's present. So as a matter of fact, with my collaborators in United States at UCLA, my former institution, Maxime Cannesson, who is the department head of ICU care in UCLA, and some of his other clinicians, we have developed several systems that are very related to what you are saying. So exactly looking at complications after surgeries in hospital, and who may develop complications and how long they should be sitting in the hospital. So yes, this is very, very related. And I would say here is where machine learning may be at its best, because it is this utilitarian topics, how long should somebody sit? What will be can we say something about the impact of keeping the patient longer in the ICU, or keeping the patient longer in the hospital, or quite the opposite? And when should they be coming back? And what are the interventions we can give to them such that they do not come back? Because as you all know, in the United States, everything is about, let's say, monetary part as well. And that is very important, that when you discharge a patient, if you discharge him too early and he comes back within 30 days, then there are repercussions associated with this.
Sure.
So that's a topic that has been very vibrant.
So we should again send the message that people, groups looking for that, should be in touch. I'm going to ask Michael Power, one of our consultant colorectal surgeons, who's got a question for you.
Thank you.
Thank you, Mihaela. Excellent talk, and I can definitely commend your revolutionising healthcare, having tapped into a few of those sessions. So really can commend that to colleagues. A couple of quick questions. What are your thoughts about how we can build in safeguards for machine learning models, the dangers of them propagating inbuilt biases, whether they're gender-based, race-based, or other things, and how we can work on not propagating those biases in using the models in the future? And then a quick second question was, I was interested to hear about your comment about interpretability and talking about machine learning no longer being a black box. It may not be to data scientists, but it still is to clinicians. And how do you overcome, I know you've mentioned it a little bit, but how do you overcome clinicians' inbuilt skepticism and gain their confidence in adopting what they see still as a black box model?
Michael, thank you so much for that. So many good questions. So let me start with the second one and move to the first one, if you allow me. So first, I want to say that if any of you has time and is bored after in an evening, please take a look. I've given a talk that's longer and more comprehensive about just interpretability, and I gave it to clinicians. So this was at the Royal College of Physicians just before the pandemic started in February 2020. So it's called Turning Black Boxes into White Boxes. So that talk is much slower and much more comprehensive, and it's just about interpretability. So you can just Google Mihaela Turning Black Boxes into White Boxes. It was a Turing talk, but it was a Turing talk aimed at clinicians. And I have a very nice discussion at the end. That's number one. But you are very right that no matter what's happening, the clinicians will need to be involved. And I see that at twofold. First, I see it through these sessions of Revolutionizing Healthcare, where we understand what you need and how to make you comfortable with these tools, and also where these tools fail, which will lead to the first question you asked. So I think one is conversations, such that we understand each other. We understand, it is complicated, I think, to break these boundaries and have meaningful conversations between machine learners like me and clinicians like you. So I think having these conversations helps. That's the reason I started Revolutionizing Healthcare. But as a tool, I'm building right now this idea, this new type of machine learning that we call quantitative epistemology. And its goal is very much around this, trying to have conversations. That's the reason I say often clinician-machine ecosystem, where clinicians can have conversations with the machine, ask questions, teach the machine. Conversely, the machine can provide the clinician with all sorts of explanations. and they can co-evolve into a partnership where this genie, the machine, is supportive of the clinician. And then this is where, in my opinion, kind of hopefully it ends. It is there, sitting there as an assistant that can be invoked, that can be not blindly trusted, but it can be conversed with anytime is needed for support or for a recommendation or for an additional analytic. This is how I hope things will evolve. I hope I can recruit a few of you to build this with us, because how we want to envision this machine learning ecosystem where man and machine interact. If any of you is interested and has a little bit of time, I need clinicians to help us build this, because this is a different type of machine learning. Is machine learning really as support for humankind rather than machine learning of replacing humankind? So hence, how to build that right such that it's truly supportive of us is challenging and requires engagement. So I hope I recruited you. Now on the other question about fairness and biases, that's a very important research agenda. And I would dare say that's more of a research agenda right now. Our group is doing a lot of work, and other people around the globe are doing a lot of work on that. We increasingly try to learn both. So we could do two things. We can try to look at fairness and try to see if certain fair rules are indeed complied by the algorithmic model that has been developed. So indeed, whether certain unfairness, let's say, is propagated in the system. But another thing that we are doing as we speak is we are trying to understand the role of data in issuing certain types of predictions and trying to understand uncertainty, not in the output, but in the input. Trying to understand whether there are regions of the data that we don't have enough patients on, or that the patients that we have a particular characteristic that's not well represented. And what is the effect of this data on the model that's learned and the predictions that are made? So there is a very big paradigm on data-centric machine learning, which is more of a buzzword, but I feel that what's great about that part is that we learn about these biases and the impact of these biases on the model that's learned.
Mihaela, thank you. That's absolutely fascinating. I'm sure there'd be more questions, and indeed, Joseph Cherian has posed some online, 3 or 4, and I'll perhaps, given that we're out of time, it might be a good excuse for Joseph to be directly in touch and perhaps even start a collaboration that way. Hopefully, I mean, it's been somewhat mind-blowing to me as a simple surgeon, seeing all this amazing data and how it can hopefully affect and improve patient care, and work with rather than replace doctors. So it's really exciting, and I think fantastic for us as clinicians in Cambridge to be able to work with you. So hopefully you'll be able to get some collaboration from those present tonight and those who watch this subsequently. And I'll just finally again thank you very much for giving up your time, and
no, thank you very much for listening
enriching
to
our
me.
evening. It's been really
Thank
fascinating.
you very much. Thank you very much.
Exciting times ahead, and thanks for your time.
Thank you very much.
Thank you. Bye-bye.
Bye.